Hello, welcome to our program, The Basics of Neurofibromatosis. I'm Barbara Levin, the Executive Director of Neurofibromatosis Mid-Atlantic. I want to thank you so much for joining us for this very exciting and informative event. We're very happy to be sponsoring this program. NF Mid-Atlantic is a nonprofit organization based in Baltimore and covering the Mid-Atlantic states. We've been around for 33 years, and we remain committed to our founding principles of supporting people with NF, their families, their caregivers, their circles, and anyone who has an interest in NF. We have embarked on a special effort this year to help combat the isolation that can happen when someone is facing an incurable disease, such as NF. We also sponsor live chats, and we will be presenting a series of educational seminars to raise awareness. At the end of this presentation, we will have a limited time for some questions. It is my great pleasure to introduce Dr. Maria Acosta, a child neurologist with a special interest and experience level in developmental disabilities. She has been working for more than 20 years with children and families with neurological conditions like ADHD, autism, developmental delay, and learning disabilities. She is the clinical director of the Neurofibromatosis Institute at Children's National Hospital in Washington, D.C., and director of the neurocognitive program at the Neurofibromatosis Institute. She has participated in several national and international projects in the genetic aspects of ADHD. Her clinical work has been fundamental in the identification of genetic markers associated with ADHD, and she is currently involved in several research projects in neurofibromatosis type 1, learning disabilities, ADHD, and associated comorbidities. Her main research interest is to find biological markers for learning disabilities and potential biological targeted intervention. It is my great pleasure at this point to introduce Dr. Maria Acosta.
Thank you so much, Barbara. Thank you for the opportunity to talk today about neurofibromatosis, and I hope that I can provide some general information to help to clarify some questions that parents, children, and families with NF has regarding this condition. I would like, first of all, to outline what are the objectives that I would like to cover during this presentation. First of all, I would like to describe what is NF, to try to understand how we got it, why we have NF, what are the clinical manifestations of the condition, how these conditions impact my children and my family, what should I do about it, what type of tests, evaluations, or medical studies are necessary as a part of the diagnosis and interventions, and how we can treat and what is possible to treat in NF. I think that if I can cover some of these aspects, would be I would be very happy about that. First of all, what is NF? Neurofibromatosis type 1 is a genetic condition. What means a genetic condition? It means that it's a problem that arises, that is transmitted from very early, from the formation of the baby, just from the conception, and affects the cells that form an individual. We are all formed by a bunch of cells. We have cells in everywhere. We are millions and millions of cells together. Each cell, it has some genetic information or coding information that comes in packaged in the chromosomes, and those chromosomes has also something that is called the genes, and it's the information that we get from our parents. 50% of the patients have a parent that has NF. That means half of the patients will have a relative, a parent, also a grandparent that has the condition. However, one important thing to keep in mind is that because I have a father with neurofibromatosis, I cannot assume that whatever are the clinical manifestations that he or she has, I am going to have the same. Not all symptoms are equal in all patients, neither even in the same family, and the severity of the same condition or the same complications are not the same in family members. And that's very important to understand. Let's understand a little bit about genetics. This beautiful baby, as I mentioned, is a bunch of cells together. Cells in his eyes, his mouth, his lungs, his skin, everywhere he is just the collections of millions of cells. And all cells are more or less the same in terms of the components of the cell. This is like having a house. All houses has a kitchen, maybe a garage or not, or a space for the car, a bedroom, etc., etc. The cells are more or less the same. Not all houses are equal. Not all cells are equal. One of the important components of the cells is the nucleus. That is this that I am showing, this center round blue center of the cell that contains the genetic information. The genetic information comes in packages that are called chromosomes, and we get chromosomes half from the mother, half from the father, and here is more or less how they look in a study that we do. This is a chromosome 1 from one of our parents, and this is chromosome 1 for another parent. And you see what happened with these chromosomes is that they are just packs of genes, and genes are basically the coding of all the manifestations that we have, from the color of our eyes to our behavioral manifestations, mood, how we behave, all have a genetic component. What happened in neurofibromatosis is that for reasons that many times we don't understand, one of these genes in the chromosome 17 is damaged because come already with a lesion or a damage from the parents, or because during the conception an accident happened and this gene is broken. That is what happened with neurofibromatosis. And basically is the damage in a gene that produces a protein that is called the neurofibromin and is located in the chromosome 17. And because this protein is almost present in all the cells of the body, but the function can be different, well, it somehow is going to affect almost all the systems in the body of patients with neurofibromatosis. Again, as I mentioned before, 50% of the parents have the condition, but in 50% of patients is something that is called de novo mutation. It means the parents don't have the problem, but the babies, as an accident during the conception, got this damage on the gene. One important thing that we have to have in account is that after you get the damage, your children will have 50% chance to have other children with NF. It's not anymore the same risk of the general population. Once you have the mutation, 50% of your kids would have the risk to have the condition. One important thing to understand is that the risk is for each pregnancy. It's like flipping a coin in each pregnancy. If I flip a coin, I can have it or not have it. Doesn't affect my next kid. My next child also needs to flip a coin and may have or not have. That's the reason why you see families that sometimes has 2, 3, 4 members affected when one of the parents is affected, and sometimes you see nobody affected because it's the risk, it's a chance in each pregnancy. That is very important to understand. As I mentioned here, we get the genes from and the chromosome from the father and the mother, and that is what happened in each pregnancy. You have these options. If this blue chromosome is the one affected, basically there are 50% possibilities that these patients don't have NF and 50% of have. But you only are going to have one baby for these 4 options. It means that you will have any of these options in each pregnancy. As I mentioned, the expression of the condition is very variable. We see, for example, this family where all babies affected. Mom has NF, and in her case, all the babies has NF, and you can see the spots of them. And today, after many years, they also have different manifestations. Or in this case, like the gentleman that has NF, and he has a very mild disease, but we don't know if his baby is going to have a mild disease or not. Unfortunately, we cannot predict what is going to be the future of a baby according with what severity is the disease in the parents. What are the clinical manifestations? Maybe you know this much better than I. You all have seen the hallmark or the most frequent way to identify patients with neurofibromatosis is because the café au lait spots. They are very typical. They have many café au lait spots, more than we expected in the general population. We all can have one, occasionally two. When we see children that the parents are for different ethnicity, sometimes we see this difference in the pigmentation of the skin, but the café au lait spots are very specific for NF. We also see inguinal or groin area freckling, and basically it's those areas that are not exposure to the sun where you have to see the freckling. Bone defects, optic nerve gliomas, plexiform neurofibromas, leaf nodules, dermal neurofibromas, and family history of NF. These are probably the main manifestations that we look for to make the diagnosis. But as I mentioned before, this is a multisystemic disease. It's because the defect is almost in all cells in the body. You can see that you can have affection of the brain, the lungs, the kidneys. For that reason, it's very important to having a periodic checkup looking for other manifestations. Most commonly, we identify them, but occasionally we find other manifestations that are not as common, and also only with clinical evaluations, periodical clinical evaluations, we can identify them. Another important part is to understand that the clinical manifestations of the neurofibromatosis are different along the life. The lifespan of the manifestation is very variable. Some of the manifestations are present early in life, others start showing up later. For example, the café au lait spots and the plexiform neurofibromas most of the time are present at birth or very early after birth. Bone lesions like tibial dysplasia is also present most of the time. However, optic nerve tumors, hypertension, learning disabilities, scoliosis start to appear later in life, in the preschool to childhood age, and some manifestation can take only place until the adolescence of adulthood. The clinical manifestations are very variable. One important thing to take in account is that 50% of the patient has a very mild condition, and this is very important to understand. Now we are looking to many more patients that have the diagnosis because it has becoming very important, and there is a lot of awareness, and probably because we have spending a lot of time educating the society, the community. We have been talking about this condition, and now those patients can be identified, first of all, earlier, and second, those patients that probably nobody paid attention before, now we can identify, and we have recognized that many have a very mild condition. Fortunately, only 20% of the patients will have severe medical complications. And many of these medical complications, today we know that could be treatable, and that the prognosis is much better if we identify them earlier than if we wait for they be severe and complicated. I always feel that little problems have little solutions, and I always tell my patients, I hope to see your kid or your child every year in our clinic, to have a very boring relation, to say, hi, Dr. Acosta, everything is fine, no changes since the last visit, he is doing great, no problems, and I have to say, fantastic, come back and see me in 1 year. This is very boring, but that's what I would like to have in all patients. But also I would like that if anything happens, I can identify early when it's not a severe impact for the life of that child, and the complications in terms of medical care, appointments, visits, and frustration can be solved with time. We are not able to predict, as I mentioned before, who is going to have good course along the life, or who is going to have complications. And that's the reason why we need to see the patients periodically. That's the reason why we do tests, we do clinical examinations to be able to early identify problems. And also because science is progressing, we are now having opportunities for treatment for things that they were not possible to treat. In addition to that, we are still learning from our patients. When I started working in neurofibromatosis approximately 7 years ago, there were many things that were not described in patients with neurofibromatosis. And that now, after seeing many and many times similar manifestations, we have learned that they have higher frequency of autism spectrum disorder, that they have very high frequency of pain, that they can have anxiety, depression, sleep disorders. And all of them can be treated and not only avoid the complications, but also to improve the quality of life of the kids and the families too. I'm going to show a series of slides with some of the manifestations. Again, you probably know this much better than I. These are kind of the typical café au lait spots, and you see sometimes are just round and kind of very well defined. Others are very big and difficult to identify, like this, for example, that is in the skin. But in general, this is the hallmark of the condition. The axillary freckling in this case, but also in any place that is not exposure to the sun. Like, for example, this is not as typical for NF because you have exposure to the neck very frequent to the sun. But these areas that normally you don't go to the beach with your arms up all the time are very important to consider that this is abnormal freckling in areas that normally are not exposure to sun. Dermal neurofibromas, there are many, since these very small ones, sometimes, or these more severe, sometimes are more easy to touch and to feel than to see because they are not clearly protrusions over the skin, and there is more like the sensation when you touch them. Plexiform neurofibromas are extensive tumors that come from the covers of the nerves that basically follow the distribution of the nerves, and that can grow abnormally and produce some like these. For example, all these bright lesion here is a plexiform that covers the shoulder and the arm in this patient. Sometimes like this is very extensive, but despite of being very extensive, it's only just the cosmetic implication because it's very superficial, doesn't go deeper into the skin or the spine or any organ in this patient. It means the location is very variable and could be in any time, in any place. The growing, the manifestations, and the impact is also very variable. Sometimes like this grows over time. This little girl has here at 11 months, and you see how it grows over the time, and at 3 years is a very significant growing, requiring evaluation, potential treatment, and sometimes consideration for surgical treatment. Sometimes we just find it as a part of a study like this MRI, that all this bright vision, this is the kidneys, this is the belly of the patient, the abdomen of the patient, here the kidneys and the spine, and all this is located in the pelvis of the patient. Sometimes produce symptoms, sometimes don't. And in general, we try to be very conservative in treating those, especially if they are not producing any abnormal symptoms. Another of the manifestation is the leash nodules, and I have this series of different pictures that show how they look like in different color of the iris of each patient. Many children with NF don't have those, and they tend to appear after the age 4 or 5. That means that many times babies, when they go for the first evaluation, we don't see it. They don't impact at all the vision. They don't produce any visual problem, but it's kind of also the hallmarks of the NF. This is very similar to the café au lait spots. One of the big concerns that we have in neurofibromatosis is the high association with optic nerve gliomas. And basically, it's a tumor. This is the eye. This is the eyeball. This is the nerve that connects the eyeball with the brain. And basically, it's a tumor that grows here. And this is kind of a normal nerve, optic nerve. What happens in neurofibromatosis is that you see, and you trust me, this is a thick, very thick, what I am going around with the pointer is the border of the optic nerve glioma that is already quite big. And this is what we don't want to happen. This is a huge tumor that probably has been growing for a long time, and it, you see, has producing protrusion of the eye, what means that probably the vision in this kid has been already compromised severely, and probably the possibilities to preserve the vision in this kid is very low. That's the reason why we are very strong about trying to identify this tumor, because today our treatments, chemotherapies, other interventions that can help us to prevent that this happens. This is also a series of exams. This is like another optic nerve glioma. This is not a protrusion, but you can see it's like a thick, and this is how in pathology you will see it's like a thick a nerve. That's the other reason why we do eye examination. The ophthalmologist will see that this is an abnormal protrusion in the front of the eye that indicate that something is wrong. And a patient with neurofibromatosis probably is just an optic nerve glioma. Brain tumors are also more frequent. We are not going to talk about a lot about these. They are more frequent in patients with neurofibromatosis, less frequent than many people in the general population believe, but still they're important to be identified. There are other manifestations like this that maybe you have here, that when you have an MRI, the radiologist sends these very fancy descriptions about something that calls UBOs, basically something that we don't understand what they mean, and not bright objects, very fancy name for something that we don't understand, or T2 hyperintensity, that is basically the description of the MRI sequence that is T2, and because they are bright, is hyperintense. They can be sometimes difficult to differentiate from tumors, but we know that they are not tumors. We don't know what they mean, but they show up in some specific part of the brain, and we believe that it's related with the development of the brain. They tend to be present in almost all patients below age of 20 and tend to disappear after age of 20. It means only few patients older than 20 will have these T2 hyperintensities, but most of the children will have some. They change over time, and that's one of the ways that we can identify and differentiate from tumors. In an MRI at 2 years, they can be in one region of the brain, and at 5 years or 7 years can be in a different region. That's what is important, that the MRIs need to be done in places where the neuroradiologist has expertise, because that would decrease a lot of anxiety for families, and sometimes they can just be part of the evaluation without any repercussion. This is another T2 that is very bright and sometimes can be mistakenly associated with a tumor, but in real they are not tumors. Other manifestations include something that is called bone dysplasias, and basically are bone defects that can occur in different parts of the body, including these. Like if you compare here this MRI and these, basically you see this straight line here. Basically this is the separation between the brain tissue and the eyes. If you look at here where it's all these arrows, you see that it's a little bumpy here, and it's basically because the bone is not well formed here, and the brain somehow is pushing against around the orbit. In this case, most of the time they don't produce any symptom or any complication, but it's something that is seen and associated with NS. Other bone lesions include fractures and poor healing of long bones like this in the tibia, or congenital fracture like this baby that just was born with that. Recently, it's a rare complication. It's not very frequent to see. It's not very frequent to see a patient with bone dysplasia, but when they occur are very difficult to treat. And in general, we are very pleased that recently one of the progress has been to try to develop treatments that can stand and benefit those patients with less frequent fractures and with more bone tissue for the long term. Other complications are scoliosis. We talked last year in our family meeting about the scoliosis. This is especially important in kids in school age, and many of you that attend to my clinic have seen that one of the most important things that I do is to pull the chair up to the patient and look for the scoliosis, because that's something that can be identified and treated with braces and other orthopedic interventions. And sometimes it's very easy to identify, and parents sometimes call us saying that basically they show that the shoulders are uneven, or the hips are uneven, or that the spine looks kind of weird in terms of the shape. And if you look at this cartoon, this is more or less what you see here in this patient with scoliosis. Basically, the shoulders are uneven, the hips are uneven, and the curvature of the spine. Patients with neurofibromatosis has a higher frequency of scoliosis, and they tend to progress, especially around the teenager age. And we like to be following them very close, because we can prevent the progression of the scoliosis in many cases with very good orthopedic intervention. Other medical problems include learning disabilities and developmental problems, and today we know that despite that these kids and these patients are smart, they have difference in how they learn and how they process the information. Also, we know after the experience of seeing many patients that babies with neurofibromatosis can have some difference in the development that can be seen as early as 15 months. It means that if we see that the development is not right on target, we can give information, recommendations, early intervention plans to parents. And again, little problems have little solutions, big problems need bigger solutions. That means that if we have a mild developmental delay, many times parents can just make a plan to play and do some intervention at home, and they can catch up very easily. Sometimes if we wait longer, maybe they will need intense therapies and other types of interventions. We also have identified that other problems like endocrinological problems, we are aware of the risk of osteoporosis, and that's one of the reasons why it's kind of I give a prescription for exercise to all children. One important thing is that whatever we acquire as a child is something that is going to be easier for us to continue doing for the rest of our life. All studies have demonstrated that being a woman, and as we get older, we have more risk of osteoporosis. But in addition to that, patients with neurofibromatosis has higher risk of osteoporosis. For that reason, I think that all boys and girls need to do active exercise, but boys are better with exercise than girls in general. For that reason, we need to encourage our girls to, since very early in life, to do any exercise. Running, riding a bike, swimming, whatever they like, but they need to be active, and they need to do at least 3 hours of exercise, intense exercise per week. That's very important to prevent all these complications. Sleep disorders, chronic pain, anxiety, and depression, they are other of the characteristics that we have found in our population, and that we are working right now to do a better characterization and also to provide better options for intervention. How this condition affect my family? Of course, having neurofibromatosis as any other medical condition increase the need for medical care. However, it's important to understand that this is not different of any other medical condition. If you have asthma, you need to take care of the risks that are associated with getting asthma attack during the spring, when the allergies, when you have cold infections, etc., etc. That means that it's important to understand that we need to provide the resources and be aware of those problems to be prepare for any medical complication. These kids and children have risk for learning disabilities and developmental problems. That means that what implies is that we need to be aware of any mild problem that can be present, and instead of blaming the teacher because he is not learning to read, we need to think, it's really the teacher, or maybe he needs some help to learn to read more efficiently. Many of these children, and in general all the patients, need close follow-up and pay attention to any symptom. Anytime that you see something that is concerning to you and you don't have an answer, or your pediatrician don't have an answer, please contact us. Contact your physician, your neurofibromatosis expert. Remember, neurofibromatosis occurs in 1 in 3,000 individuals in the general population. That means that your pediatrician probably has seen 1 or 2 patients in her or her life. That means that the fact that she or he is able to identify, think about neurofibromatosis is good enough. She doesn't have to have the answer for the neurofibromatosis related problems, but I should be able to help you to find an answer. And if I don't have an answer, I need to help you to try to find who can provide the better answer to those questions. That please keep a good contact with your pediatrician, your NF doctor, for any unusual symptom that you cannot explain for other reasons. One important thing that I see quite often in this population is that we really need to advocate for ourselves. The more you know, the more the community is going to be aware. And many times I have great patients and great families that come to my office with questions that I don't have the answer. And I love that, because it means that they have doing research, they have been looking for potential explanations, potential interventions, and instead to make me feel uncomfortable or happy or unhappy, I feel very happy because it gives me the opportunity also to research that subject and try to find an answer that I didn't have before. The more you know, the more it's going to be for your family. You can speak up and explain the teacher, your class, the classmate of your kids, the mother of the classmate of your kids, what is neurofibromatosis. You can obtain better medical support when you go to your insurance and you try to get some services, because sometimes they don't understand that having learning disabilities is not the same as having a bad teacher. When you have neurofibromatosis, you really have a biological reason to have difficulties in learning, and this is a medical problem like any other. You need to find a group of specialists that knows the condition that you can access when you really need. Even for those families that are not close to a very sophisticated center of attention, it's possible to coordinate attention and medical attention between your local pediatrician and a center that can provide advice and kind of consultation. And please be aware that you are the most important advocate of this condition, and we are all to help, but you need to be proactive at teaching and letting the people know what is neurofibromatosis and what is not neurofibromatosis too. How we make the diagnosis of neurofibromatosis? Basically, today we know that this is a clinical diagnosis. The diagnosis is done examining the patient in most of the cases. When we see a patient with neurofibromatosis, once we do a neurological and physical examination, we should be pretty sure that we are very close of say yes or no. Sometimes it's not as easy because the cafe au lait spots are not typical, or because the freckling is not really clear, or because we don't have other signs that can be associated with that. In that case, we go to other exams that also help us not only to make the diagnosis, but also to evaluate the complications. We used to recommend an eye exam to see if there are lesion nodules, but also to see if it's any sign of possible optic nerve gliomas or visual deficits. Most of the time we don't request genetic testing, but over the years genetic testing has become more available and is a very important source when clinically we cannot really be sure if they are compatible designs or not with neurofibromatosis. Neuroimaging, like brain MRIs, are very useful to try to evaluate complications. Tumors, optic nerve gliomas, vascular malformations are some of the things that you can see in patients with NF, and that is important to identify to provide the appropriate treatment in every case. Developmental evaluations and cognitive evaluations is something that we would like to do in most of our patients. Sometimes not because we are very concerned about severe developmental problems, sometimes just because they are kind of borderline and we would like to follow. Sometimes because we feel that if I know how I do learn, what are my own skills to better learn specific subjects, I can probably do more effort in develop that and try to accomplish those that are difficult. And if I, as a mom, understand what are the skills that my kid is very good at and where he has difficulties, I can try to put together a plan to compensate one another. In general, I always tell the parents that we are not to be perfect. We should not be good for everything. And we pick to be a doctor because probably I cannot be doing professional dancing, because everybody is good for some things and not good for others. But that's the combination, and the knowledge of that is what is going to provide the best of us for the long term. Close follow-up, close evaluations. We tend to see babies, every baby below 5 years of age, we like to see every 6 months, and every baby or every young child after 5 years of age once a year, like the regular checkup that they do with the pediatrician. And as I said, when they go to college, anytime that they want to see us, that probably is more than every 2 years. As I mentioned, we like to have them around once a year. Anytime that you have a problem, you need to contact your doctor. Anytime that you need information or help, please contact your doctor. Instead of looking in the internet about information that is unreliable, sometimes not real or not associated with what you are looking for, call your doctor, call the person that knows more about NF and get answers directly from them. If you have access to multidisciplinary clinics, they are a very good resource. They help you to coordinate care, several services. Sometimes they are very long visits, but you can be sure that you can save time because you can see several experts in one day, and also you are going probably to get the best advice possible when you have a group of experts in neurofibromatosis working all together, and you can get from them the answers that you expect to have. Now let's talk about how we treat neurofibromatosis. I have mentioned before, and I will repeat it again, the best way is identifying early any medical problem. Basically, the big difference between the care that we provide for patients with neurofibromatosis today is that we don't wait to the complications to produce a permanent damage to treat them. We try to see when a potential complication can be present and avoid that become a complication. When a medical problem has the potential to be growing and becoming a significant problem for the patient, and how we can treat to avoid that. This is probably the most important part of the medical treatment for neurofibromatosis right now. Get advice and treatment for experts in the field is different to have a brain tumor if you have neurofibromatosis. It's different to have optic nerve glioma if you have neurofibromatosis than in the general population in terms of the prognosis, the treatment. Please get advice from experts in the field, and don't wait until the complications are impossible to avoid. And one important thing, be part of the research studies. What we know today about neurofibromatosis is the result of a fantastic combination between funding institutions like the Department of Defense, the NIH, the Children's Tumor Foundation, the Gilbert Institute where I work, and many other sources of research that has funded the research for many years and that allowed us to provide better opportunities for treatment in patients with neurofibromatosis. But we cannot do research studies if we don't have patients that are willing to help us to understand. And I can show you great examples of how much we have advanced just because we have been able to have the collaboration and the synergistic work between funding institutions and great families and patients that has allowed us to advance our knowledge. This is a condition that we cannot cure. There is not a curative treatment for neurofibromatosis. However, many things in medicine you cannot cure. We cannot cure diabetes most of the time. We cannot cure hypertension, but we can prevent the complications. And this is, again, the main message that I would like to deliver today. If we can do an early identification and prevention of complications, we probably have accomplished a very significant part of the treatment that we would like to have in patients with neurofibromatosis. We hope that in the future we will be talking about how to avoid optic nerve glioma, how to avoid that a patient develop a vascular complication, how to prevent that they develop learning disabilities. But at this point, if we can identify them early and treat, this is very important. One of the most interesting things is that despite that all the community, parents and researchers had focused in the serious complications like tumors, etc., the most frequent problem is learning disabilities, and that's probably the one that is more impacting in the long term. Unfortunately, sometimes we don't consider that as a very severe or as severe of any other medical problem. However, we need to understand that giving the patient the opportunity to learn and be independent is probably the best thing that we can do when we have passed the serious risks of other complications like tumors. They need to be independent. They need to have a normal life. They need to be like any of us. And those is only things that we can provide if we support them along the life. Many patients with neurofibromatosis have a normal life like any of us. And our job is to increase the numbers of patients that can live independently and have a regular life like any of us. There are many research studies going on, and I just want, again, to mention, and if it's anybody that is interested in learn more about any of the studies, please don't hesitate to contact us, and I will be more than happy to provide information. But, for example, there are many studies for treatments for plexiform neurofibromas funded by the Department of Defense, also at the NIH. There are many studies, especially in our institution, for treatment of learning disabilities with medications, without medications, with computer training programs, and any other intervention that can be potentially useful for these patients. We have been working in an early detection of developmental problems in children with neurofibromatosis for several years, and I am going to show you a very brief result of what we have been able to accomplish that is very important for the babies to come. Treatments for brain tumors and optic nerve glioma. As you know, Dr. Roger Packer, the General Director of the Neurofibromatosis Institute, is a very well-known pediatric neuro-oncologist, and he has developed interventions and treatments specific for optic nerve gliomas in patients with neurofibromatosis that are very different of those optic nerve gliomas that are present in patients without neurofibromatosis. Recently has been also developed interventions for those bone lesions that has been hard to treat because the number of patients is very small. However, with the multidisciplinary, multi-center approach, we probably have right now many institutions that are willing to coordinate potential clinical trials to try to benefit those patients. studies looking for how to improve the quality of life, and quality of life includes better opportunities for work, for education, less risk of anxiety, depression, more independent life, pain management, etc. are also available. At the summer camp, we have a great summer camp that the kids attend to that during the summer in July, 1 week. And in addition that they have a fantastic time, we use it a lot to provide education and interventions in terms of social skills, independent activities, and self-esteem. I just want to mention 2 little studies that are very exciting, because it's kind of prove how working together as a community we can approach and find very, very exciting results. I just want to mention briefly this study is just published in April 2012. It's a group of patients that we saw in our institution, and we used as a part of a study that we were doing looking for lovastatin, a cholesterol medication for treat cognitive deficits. And if anybody is interested, I can provide the full study and information, and here is what is published. But I just want to show you very briefly what happened here. If you look at this, this is a normal control, and what you look, this is the brain, and these colors make show basically how areas of the brain are associated when you do something or when you do nothing. Like, for example, these areas here in the frontal, this is the nose of the patient, in the frontal areas are connected with the back. In patients with neurofibromatosis, before any treatment, there are very little connections. That's probably the reason why they have difficulties processing information. And then after we treat, we saw that there were some improvements in the treatment. Despite that this is a small study, it's a very exciting because it opens the opportunity to try to identify why patients with neurofibromatosis have problems learning, and also how we can assess the interventions in this population. The other study that I also wanted to mention, I mentioned it briefly, is the early identification of developmental problems. In summary, we have followed around 100 babies between 6 months and 7 years, and we have seen that we can identify developmental problems in babies as early as 15 months of age. That means that if we can identify those deficits and provide intervention as early as 15 months, probably we will decrease the impact of these developmental problems in the long term. We are still looking for these patients, and we are looking for the long term to see if when we intervene these babies early, we can demonstrate that they do much better. And also we can request to the insurance companies to provide intervention for these patients as there is clear that is an impact in the long-term prognosis, and that the biological problem is responsible for that. I just want to mention a couple of slides about our institution. We are the Gilbert Neurofibromatosis Institute. We are part of the Children's National Medical Center. We are probably the largest center for care of patients with neurofibromatosis in the country, with more than 1,000 patients. And we provide service with a very important family and patient support and education to the community. We are leader in many areas of research, but especially learning disabilities is my main area of interest, and tumor as the main area of interest of Dr. Roger Packer. We also are developing some pilot studies in SINs and other problems like pain, sleep, and other comorbidities. These are some of the members of the NF Institute that you will see if you visit us at any time, and other ones that I don't have picture of them, but are also very important, clinical coordinator, research assistants, and neuropsychologists. I would like to invite, we do a family meeting every year in May. This year is going to be on May 5th, but it happens every year in May, and we try to get a feedback from the community about what you would like to hear about NF. If you can attend to this year, it's fantastic. If not, save the date for May 4, 2013, and let us know what type of topics would you like that we cover in that presentation. I want to leave and finish with our contact information. Please don't hesitate to contact us at any time if you have any question about any of our clinical care or any of our research studies. Thank you.
Thank you so much, Dr. Acosta. That was wonderful. We are inundated with questions. Unfortunately, we only have about 10 minutes to take some questions. And if you have about 10 minutes, I'm going to go down the list and ask you a couple. The first question comes to you. Someone wants to know if NF affects one race more than any other.
I am not aware of any study that has demonstrated that it's more frequent in any race. We know that it's frequent in all ethnicities and occurs in all races. But I don't know any study that has showed that it's more frequent in one population. Probably large population-based studies are necessary to identify that. It means like you take a population of all the city in different continents and compare the frequency. And to my knowledge, there is not.
Thank you. If you have NF, does it change as you reach old age?
Yes. As I mentioned in one of my slides, there is a lifetime changes in the manifestations. Basically, as a baby, you will have some problems that are not present, but you can have other problems later on. For example, things like the café au lait spots and the plexiform neurofibromas probably are present since birth. But optic nerve gliomas are present mainly in the first years of life, like below 10 years of age, but hypertension, tumors in other organs tend to appear later in life. Endocrinological complications also tend to be present later in life. And even in things like development or learning disabilities, they can change, probably not because the condition itself, but also because the requirements of the environment. Dermal neurofibromas are more frequent later in life, and there are some that are, for example, associated more frequent with pregnancy. Pregnant women tend to have increase of the dermal neurofibromas during the pregnancy. In many of them, they tend to regress after the pregnancy, in others, not completely.
Thank you. It is a current topic. Is there a relationship between breast cancer and NF?
We don't know yet, and actually I would like, this is one of the studies that I didn't mention in my presentation, but I would like to invite all the women with neurofibromatosis, with or without cancer, but all the women above age 18 to contact us. We are doing survey. It's not, the study doesn't imply any testing. It's only, we are trying to identify in the population with patients with neurofibromatosis, what is the incidence of that. There are some researchers, especially in Denver, that feel that breast cancer tend to appear earlier in women with neurofibromatosis. And if we want to impact the health policies about mammographies and early detection, we need data to provide to the government and organisms, health organizations, that why we need to identify those early. We hope that all women older than 18 years old can be willing to answer some questionnaires about family history of breast cancer, any history of breast cancer in themselves, or any history of normal or abnormal mammographies. It's completely anonymous. No personal information is going to be included. But if any of you are interested or know somebody that is interested to be part of those studies, please contact us. It's going to be very useful, and the participation is really minimal in terms of time and commitment. It's just a couple of questionnaires over the phone or in person to accomplish that survey that we want to obtain.
Thank you. To that end, I want to mention to the audience that all the information for Dr. Acosta and for the Children's National Medical Center is on our website as well, www.nfmidatlantic.org. We have time for a couple more questions. Another is there a prenatal predictor of the Novo mutation?
Yes, I think that what could be hard is to identify the risks for looking specifically for NF mutation. But babies with neurofibromatosis in utero can have some indicators of abnormalities that can make the clinician, the obstetrician, to consider testing. The problem is that it's very hard when you don't have family history of neurofibromatosis to think specifically about neurofibromatosis as one of the million diseases that your baby can have. And as a child neurologist, you can imagine that in every pregnancy, I check all the list of the possible complications that any of my kids can have. And the reality is that the number is kind of overwhelming, and there is not a specific marker that can point out to that specific. I mean that sometimes the screening for congenital malformations or in utero problems is very broad and can identify that something is not correct. But probably if you have any concern, my suggestion is that you get an evaluation for one of the prenatal clinics in a center with expertise in prenatal diagnosis and evaluation. They probably can address what are your risks of not only NF, but other congenital problems.
Thank you. I think we have time for one more question, and it is, can a person have more than one type of NF?
It could be possible, but I want probably to, but could be very unlikely to say. It means I want probably to be sure that the audience understand that when we talk, what we have been talking is about NF1, and when people is talking about NF2, are talking about a completely different condition. And one of the mistakes of the assumptions that I have seen that some of my patients have mentioned to me is the assumption that NF1 and NF2 are the same condition with the difference of the severity. It means some patient has told me that NF1 is a milder condition than NF2. And that's not true. They are two different diseases. It's like having diabetes and having hypertension. You may have both, yes, but it's very unlikely that you have two different genetic defects that produce two different conditions. Most of the time, the NF1 is in the chromosome 17. The NF2 is a different completely chromosome. Occasionally, you can have café spots in NF2, but the most frequent feature in NF1 is the café spots. You can have vestibular schwannomas in NF1. Yes, maybe you can have other brain tumors, but that is probably the main characteristic of NF2. That means that despite that you can overlap one and other, doesn't mean that are related, not genetically and not in terms of etiology.
Thank you. I'm afraid that's as many questions as we have time for today. On behalf of NF Mid-Atlantic, I want to thank you so much, Dr. Acosta. I think I speak for everyone when I tell you how fascinating this presentation was. We are so grateful for your time and especially your dedication to the field of NF. I encourage all our listeners to feel free to contact NF Mid-Atlantic. Visit our website at www.nfmidatlantic.org to listen to this and other educational programs and to sign up for notifications about our events. And as always, we survive on your generosity. Please consider a donation in any amount. We have made donating very easy on our website. On behalf of Dr. Acosta and myself, Barbara Levin, I want to thank you for attending. Goodbye.
Thank you so much. Bye.